Hello, it's Mark Kris from Memorial Sloan Kettering. In my discussions with docs around the world, I've come upon a huge amount of confusion and difference in what we call progression. And that what I'd like to talk about today is what I'll call the many phases of progression on systemic therapy. I think the first thing is just to remember we really don't have a definition of progression for care. Many people turn to RECIST, but please remember RECIST is something that talks about tumor measurements, part of clinical investigation, and drug development. And it really doesn't apply to decision-making for the care of an individual patient. And again, these standards have been set up for consistency and reproducibility, not to guide the doc to make a decision whether to continue with therapy or not. So first, a couple of thoughts as to the things that you need to consider when you're making this decision about is progression happening and what to do. I think the single most important thing is our symptoms. Does a growing lesion lead to a symptom? Does a growing lesion lead to a disruption of somebody's lifestyle and their ability to live the kind of life they want? I think a second very important thing is what's the availability of an alternative therapy? If there's an alternative therapy available of high likelihood of benefit, side effects that are either equal or less than the treatment people are on, then that's a very important consideration. You know, what's next? I'll say that. Lastly, the reliability of the documentation of progression, particularly on imaging studies. Please remember, you really need about a 25% change in lesion size to be sure that a lesion has truly grown or shrunk on a CAT scan. For a PET scan, it's closer to 35%. So you got to really be careful. Has people really progressed, and sadly, has their cancer really shrunk? Also, there's some things that occur that can cloud the interpretation. And one of the common ones, and again, many, many more people know about this now, is that lytic bony lesions under effective therapy often are inapparent, but they become apparent and become sclerotic as the healing process takes place. And I think all of us have seen these cases where people had a, quotes, negative PET scan that suddenly became positive while a patient was clearly benefiting from the therapy. So you have to be really careful there in the case of sclerotic bone metastases. Also, please note that bone metastases are really not part of the even in the RECIST, the decision-making for whether or not a cancer has grown or shrunken. So bone metastases are a special situation, and you see this a lot with targeted therapies, and it's very common that people can be misled with that. Again, I think how a drug is tolerated is really important. A drug that has had virtually no adverse effects doesn't affect somebody's life quality or the ability to live the life they want. You have to really think hard about changing that treatment. You need a strong reason for that. And lastly, whether disease is growing in an existing metastatic site or there's a new metastatic site. I think that's something else that influences our decision on how to go ahead with assessing whether or not a patient has progressed. I'm going to have a part 2 to this in just a minute.